we could have come, but when your mother is sick and with an acute MI, you have to be in the hospital. So second talk will be Dr. Arun Prasad. He's in between the OTs, trying to come, otherwise virtual. The third will be Dr. K.K. Pandey, is sitting here, and in diabetic foot. And then we have Dr. Anurag Agarwal. Dr. Anurag Agarwal has requested me to prepone his talk. He's a dean of Ashoka University. He was earlier in a very important position with CSIR. So may I just do some changes because he has to leave. So with Dr. Anurag Agarwal, he will further introduce himself on the dais. He's a great friend, and he will talk about the artificial intelligence, technology, society, future of health, and artificial intelligence. But I would request you to give a little more about yourself. He is a dean in Ashoka University, what it is and what we are dealing. And before that, you were in CSIR. So just, yeah.
Glad to be here. Just give me 1 second. By background, I'm a pulmonary critical care physician. I did my MBBS from AIIMS many years ago. Did a fellowship in pulmonary critical care at Baylor College of Medicine, but went into genomics. Went into genomics until recently was the director of the CSR Institute of Genomics and Integrative Biology. You may have heard of us during the time of SARS-CoV-2 sequencing. Recently, I shifted to the Ashoka University. That's a picture of where my office is, to start a new school of biosciences called the Trivedi School of Biosciences. Today I'll speak to you all regarding emerging trends in how technology is changing the future of health. I'll confine myself due to time to artificial intelligence. One very important thing to talk about is when many of us speak of digital health, we think of it as a digital way using IT of delivering health in the old way. While that's a temporary thing, you can do telemedicine, telecardiology, tele-everything. But the real transformation, the real digital health, includes a fundamental digital way of looking things, including at genomes. Today you can measure, read, write. I don't know how many people in the room today know you can create de novo using synthetic nucleotides a new bacteria. It's already possible to edit the genome. Today, people with sickle cell disease are actually being treated for sickle cell disease. There are trials going on in monkeys whereby mutating a normal PCSK6 gene, you are able to lower cholesterol for years and lower cardiovascular risk. Just one hepatic change in one gene, creating a mutation in a normal gene. That's where we are. But speaking today and confining ourselves more towards AI, the biggest fundamental of digital health is the better half. Technology for the sake of technology will take us into directions we may not want to go. And the goal must be stated, which is to improve access, quality, affordability, but also to some degree equity and justice. And this comes in particularly for genetic engineering, where it is possible to create things that might be heritable to future generations. But do we really want to go there? One very important thing about AI that I think is not stated enough. AI, big data, machine learning are all the same thing. At this moment, there is nothing called artificial intelligence that is not simple machine learning. It comes in 4 flavors. Flavor 1, the most common, is of supervised learning. In supervised learning, a human being decides the classification. It feeds the data to the machine. The machine on its own learns a set of rules that allows it to classify as well as the human. It cannot exceed human classification because by definition we are classifying things. So even if the definition of disease X is a bad definition, the machine will learn to classify just like a human. Unsupervised learning recognizes the fact that we may ourselves do not know how to classify disease. If you went to the 1950s and looked at what COPD used to be, you will find that post-tubercular bronchiectasis, standard bronchiectasis are all part of COPD. Even asthma was part of COPD. And the reason clinicians in 1950 thought of asthma as part of COPD is, life expectancy was low. Treatments were the same. What difference did it make? you're going to give them some kind of inhaled atropine derivative anyway. So recognizing that clinicians themselves may not know how to classify disease, unsupervised learning starts the data and looks at classes within it, some of which may not be recognized by clinical practice. Semi-supervised blends the two, and reinforcement learning, you will see increasingly in ICUs, is where decisions need to be made. So situation A needs a decision, situation B needs a decision, so BP management, fluid management. Again, very nice work coming out of UK, showing that machines can do it quite well. So where is the data going to come from? A, the data would come from big biomedicine practices, and the other is going to come from us. In the first one, you are seeing massive data sets being created. The UK Biobank, tissues are being decomposed to single cells, genomics, every kind of omics is being run. And this is trying to understand health from the bottom up. Start with the genome, work upwards. The other type of data, which is far more relevant to the room today, is our data. Every time you go to a hospital, every time you get a procedure done, every time you get a test done, data is being generated. Capturing and using this data in an ethical way will be fundamental to the progress of AI. And India is trying to come out with an appropriate digital health data policy. There are challenges in either direction. If you say anybody can use the data, privacy is lost. If you say explicit consent is required, all the data we have accumulated over a decade is not usable. Finding that balance in a way that protects the interest of the patient while advancing the field is key, and we must keep an eye on it. You know, there are digital twins. If somebody in the room has bought a Porsche recently, the entire suspension of your Porsche has a digital twin. You can actually log on to see what is happening when it requires service. If you fly in jets, jet engines have digital twins. If the jet flew through a sandstorm, it knows it. It knows servicing will now have to be advanced. So GE does that for jet engines. Similarly, cardiologists, given the organ of interest, is somewhat an electromechanical one. Most electrical things can be mapped, most mechanical things can be mapped with sufficient number of sensors. And many of you implant things that contain sensors. So in arrhythmia management, it is possible in certain areas to almost simulate what will happen. If you want to create an ablation on a particular part, what will happen? So you can run algorithms, and this is done again only in Germany, in a few places right now. But you can simulate what will happen in the arrhythmia intervention, and you can lead to complications in silico. Something happens to the patient, you can come back and plan your procedure. Not too many other organs have this capability, so cardiologists are at the forefront. In any case, it's not possible always to get the data from the patient in which you want to do the intervention. That can happen only in a few patients, where you implant electrodes and all that. Neurology is the other place this is happening. So what you want to do is learn from multiple patients with multiple types of data, create the models which you apply to an individual patient, and that's the tough part. This is where we are still thinking, but cardiology is a pretty active field. It's not just about images. In many other fields, you know, images are the essence, radiology. And AI is very good with images. But cardiology is a bit more than that, so it's going to be tough. Looking at the biggest success of AI, the game of Jeopardy, where computers were asked to answer questions just like human participants. A typical question could be, this is the hat, my dear Watson. And this is the name of the hat, my dear Watson. We would know it's Sherlock Holmes. We would know it's Dear Stalker. But the biggest challenge in AI was to figure out what question was being asked. Answering was easy. Given all the information you have for every possible question, if you can figure out the question correctly, from the way humans say it in a complicated way, you can find the answer. So IBM won this competition, beat the two highest ever winning people on this game of Jeopardy, and immediately started IBM Watson for oncology. With big promises regarding changing cancer, we all know what happened, nothing much. And the reason is that in the game of Jeopardy, there are clear answers for all questions. Jeopardy answers only require existing data. But in real medicine, in biomedicine, there may not be any right answers. There may be many right answers, and the entire data could be wrong in terms of answering the question that you're trying to answer. So yes, AI is not yet ready, anywhere near ready, to replace the judgment of a human doctor in their practices and complex things, but for simple things, it is doing well. I'm going to end with a sobering example. In America, where people have insurance, they say that the insurance company is more vested in your health than anybody else. So they use an algorithm trying to figure out which patient will become sicker, get admitted, and consume healthcare. And this algorithm is used to give them extra outpatient care. In analysis that you see here on the left, the dark line are black people and the yellow line is white people. On the x-axis, you have the risk score. On the y-axis is how many conditions they have. You can see to get the same score from the algorithm, a black person had to have more medical problems. Why is that? Does AI care about skin color? Is AI biased? No. The very simple reason is, how do you know somebody is sicker? You know somebody is sicker when the time they come to seek healthcare. If a person waits to get sicker because they're poor to access healthcare, well, AI will simply adjust for it. So AI is fundamentally stupid. It does not know human nature. Imagine an algorithm like this working in India. A poor person would have to be very, very, very sick to get a score requiring hospitalization from their current behavior. So we need to learn about these things. We cannot leave it to people who don't know medicine. And engagement of doctors in this area is going to be very important going forward. And that's briefly the last message I'll end with. You have to know something before you can translate it for others, and knowledge precedes translation. Thank you.
Thank you, Dr. Anurag, very nice presentation. No doubt digital technology has changed the scenario in the treatment as well as diagnosis, and we can treat the patient even in the remote areas. Very nice.
Thank you.
But the clinical correlation